Hello there, and welcome to a video version of the launch event that we held yesterday in Leicester. Some of you will have been to the event, and thank you very much for coming. Others weren't able to attend, but hopefully this will cover most of the points that we covered yesterday, and also a recap of the online system, the portfolio system, and hopefully make that a little bit clearer for you. So to start off, I'm David Peachey. I'm the GP lead for this, working from the Nottinghamshire Alliance of Training Hubs, and part of my team includes Ali, who I'm sure you've had lots of emails from, and I work in clinical practice 3 days a week, and I'm currently working on this project for 1 day a week. So let's start. So thank you all for applying for the project first of all. And welcome to it. Things we'll cover over the next probably 30 minutes or so include the history of the GP assistant role up to now, and how that fits into the national picture with GP assistants. We'll outline how we expect the project to run, and sort of commitments from yourselves and us, and then we'll have a look at the online portal, and hopefully demo that, so that's a little bit easier for you to follow when you first get started. And then we'll also talk about how we share details, how we put you in touch with each other to support each other on this process. And we did have some questions and answers yesterday, but obviously that's not going to be possible here. So why are we doing this? Where is this desire coming from? Well, there is a lot in the press, as you might imagine, about the pressure that primary care is under. GPs are retiring early. Patients are waiting long times to be able to see their clinicians at the practice. And GPs are getting burnt out and tired, and that's why they're often retiring early. And there are lots of challenges at the moment. A lot of the traditional primary care roles, there are shortages, and the King's Fund has mentioned this as the single biggest threat to delivering the long-term plan. We're getting older, we're getting more unwell, and there's arguments to be had about whether we've been underfunded in primary care for a long period of time. Doctors, or certain doctors, are burnt out, people are retiring earlier, and there's this sort of death by admin, people are drowning in it. However, with challenges always comes opportunities. And I guess some of the things we want to work out, do some of these new roles that are coming into primary care address some of the challenges we've just talked about? A lot of those challenges we've mentioned aren't going to go away. We're not suddenly going to become younger and healthier, certainly over the next few years. And the literature at the moment, often about these new roles at the moment, says we just don't really know, but it seems to make logical sense, and you talk to people and they think it could work. And so a part of what we need to do is get that evidence base in practice. And so this is a chance at the moment to transform the workforce of the future, make it more fit for the challenges of the future, and hopefully, especially with this GP assistant role, enable each member of the team to practice at the top of their licence for as much time as possible, because that is probably the most efficient way of working, and that's why people have trained as they have done. So talking more specifically about the sort of GP assistant role, when GPs were retiring early, or when they consider early retirement, one of the significant factors they mention is the administrative burden on GPs. Now, they've been called different things over both primary and secondary care. There have been pilots in secondary care regarding medical assistance and assisting on wards and things. In primary care, there's been 2 major test sites in the UK so far. One of them is down in London, in Croydon, and the other is in Spinney in the northwest. And they both use slightly different project plans. So the one down in London was a purely administrative role, and the one up in the northwest was a mixed clinical/administrative role. But the common themes that ran throughout all these pilots have been that the GP assistants have always been recruited from within the existing staff, and all the learning has been done in-house, all experiential. So what are GP assistants? This slide is actually stolen from the Northwest pilot. And I like to say we like to think of them as hybrid sort of general practice workers, part personal assistant, part HCA. And I guess really what are GP assistants comes down to what can GP assistants do. So we envisage GP assistants being able to do some of the basic HCA clinical skills such as bloods, ECG, urinalysis. And the reason we thought that was important as part of this pilot and important going forward is it builds some slack and resilience into the workforce. We know that if a HCA or nurse calls in sick last minute, then often clinics get cancelled, patients get delayed, and it builds up work in the future. If you've got somebody else in your team who can step in and do some of, if not all of that work, then that keeps patients happier, and it keeps the continuity and the system ticking over. We also know that it's always seems to happen that it's 5 o'clock on a Friday when some of the clinical staff have gone home and somebody comes in with chest pain and you need an ECG. Now, is it the GP doing that, busy on call, or is there somebody else in the building who can step in and help out? And as I say, it builds a little bit of slack and resilience into the workforce. And we also talk about sort of supporting GPs in their work as well. Now, a lot of the things I'll mention, a lot of the things we talked about yesterday aren't necessarily going to be for every practice. Not every practice is going to have the room space to use a two-room technique, or not. They might not even want to. But these are just ideas as to ways that GP assistants can maybe help in your practice. So we know that in the Northwest, they've used GP assistants to sort of prep patients for examination. And when I say that, we all know the patients who you call the name from reception and they take 4 minutes to walk down the corridor, 3 minutes to take the coat off, 2 minutes to tell you about the dog, before telling you that they've got abdominal pain, they're going to need to get up on the couch for examination, need help from you and maybe another member of staff. And we're talking a minimum of 20-25 minutes for that consultation. Whereas, could you have somebody who does a lot of that legwork, gets them into the room, gets them appropriately undressed, maybe checks some basic observations like blood pressure and pulse, and gets a brief idea of why they're attending today. If they're likely to need examination, maybe get them up on the couch. So then the GP can come in, deal with the medical side that really is the GP that needs to deal with, and make a plan. And then maybe the GP assistant can carry on typing up notes or ordering some of the tests that the GP thinks are appropriate. That's one way that people have done it. The two-room technique is used very much so in secondary care, and it's not something that's very common in primary care, and it's something to consider. It's not something that you have to do, obviously. And something else, we also know those days when you have to admit 2 patients in the morning, you're waiting for the haematologist to call back about some urgent blood results, and you're falling behind in your clinic, you're probably running 30-40 minutes late, patients aren't happy. Whereas if there's somebody else who can be doing those phone calls for you, arranging those admissions, and maybe they may need to liaise with you at some point during that time, but they can be doing the bulk of that work while you're carrying on seeing patients, then that's it sounds to me like an efficient use of time. Also, we've talked about GP assistants being in the room during consultations, typing notes, ordering tests, and as you go. Again, it's not going to be for everybody. I'm not sure I'd like somebody typing my notes in the room, and it might take some time for patients to come around to the idea and staff as well. But for some people, that might be very appealing, and someone to type their notes, order the tests, and the GP can concentrate on the clinical decision making. And then we talk also about some of the administrative tasks. We've already mentioned sort of ordering blood tests, other tests that might be requested by the GP and then maybe authorised or signed off by the GP. And then also sort of completing the fact filling sections of lots of forms. These would often need to be countersigned by a GP, things like universal credit, mortgage forms, insurance forms. And there is some evidence to suggest that when these forms are completed by somebody who isn't a GP, they're often more accurately completed. And the thinking is behind it, these are often the things that are keeping GPs at work till 8-9 o'clock at night, because they're the things that sit in your tray and you don't get around to doing them because you're dealing with more clinically urgent things during the day. And before you go home, you look in your tray or your pigeonhole, and there's 2 forms to complete. If somebody else can take that bulk of work away from you, then that can only be good news. So in terms of the national picture, so as a result of the success of these test sites, which was mainly qualitative feedback, Health Education England decided to fund the rollout of the GP assistant role across the country. And they're funding 40 learners across 7 different regions nationally. And as the Nottinghamshire Alliance of Training Hubs, we were selected to lead for the Midlands region, and hence why you're listening to this, I guess. There are slightly different pilot structures depending on whereabouts you are in the country, but they're all feeding back centrally to Health Education England to fit in with the sort of national picture and evaluation. So these are some comments from pilots up elsewhere in the northwest, and some early evidence, I guess. And this was presented by Juliet Swift from Health Education England at the event yesterday. So the Primary Care Workforce Commission mentioned that about 11% of GPs' time is spent on routine administrative tasks. Now, when we discussed it yesterday at the pilot event, I think we all agreed that that's probably an underestimate, and that's certainly the feedback that Juliet's got when she's spoken to other people elsewhere in the country. A GP assistant mentioned there's been a huge impact regarding administration time with regard to form filling, and that they deal with most of the forms that we receive, such as medical forms, insurance forms, alleviating the pressure on the GPs. And there's also a comment from a doctor up in the northwest saying, I think it's got great potential, maintaining his enthusiasm for work and also keeping him in his job longer. And there's also a mention there of GP time saved on administrative duties in the south. So this was again a slide presented by Juliet at the event, and it talked a little bit about the approach to national rollout and the 7 different areas, and the importance of evaluation as well, because as mentioned, we need to try and prove that this works if we're going to sort of go on and develop it further, and it's going to become a more established role. And the 4 areas nationally that they're going to be looking at in terms of evaluation are the patient experience, population health, does it reduce costs in practice, and does it improve the team who are giving care, does it improve their quality of work and enjoyment of work. Some of the challenges that they've had so far elsewhere in the country often circle around the experiential nature of the learning, and this is all delivered in practice. I think originally in the northwest they had quite a significant dropout percentage, and the theory was that practices didn't really know what they were signing up for. They thought they were going to maybe have someone signed up, taken away, trained up and delivered back as an upskilled member of staff, where that's really not what we're doing. We are giving you a framework to upskill your own staff, so that was an issue initially, and that might continue to be an issue. I guess we will find out. And there's been some challenges with regards to verification and certification. In the northwest, Chester University did verify and certificate the pilot previously, and we're still waiting for confirmation on whether they'll be able to do the same again for our pilot. And also, so the evaluation's been tricky as well at times in areas, and finding the right data to capture isn't always easy with these things. But we'll talk about how we're going to evaluate our pilot as well. So how do we expect this pilot to run? So we see this being a 6-month course beginning of September and running to the end of February. we know that in certain circumstances, we know that life takes over, and for whatever reason, people go off sick. And if that 6-month period isn't going to be possible, then we will, or we may be able to extend it for certain people, depending on the circumstances. There's no point us pulling the rug from under your feet if you're near the completion of this at 6 months and need a bit of extra time to finish. There are 5 main domains of administration, clinical, communication, managing health records, and the care certificate. And I'll show you those on the online system shortly. And then the internal verification is from the GP mentor stating that the learner is competent to do those skills and is achieve those competencies. And that's where the majority of the verification comes from. We mentioned accreditation earlier, and as mentioned before, the Northwest had Chester University, who verified 5% of the portfolios, and after that sort of awarded certification. We're still in communication. Health Education England are still in communication with Chester University regarding whether they're able to do that for the other regions, and we're waiting for confirmation of that. So I don't want to promise anything at the moment. However, what we can say is this exact same framework and this competency framework has previously been a fully accredited programme, and so we are very, very hopeful. And I think all the different regions and Health Education England centrally are very keen on the importance of verification and accreditation, because what that means to the GP assistants when they complete the course. So in terms of time commitments, what we would expect, how long will this course take of your time? We would expect half a day a week for the GP assistant to have either a tutorial or training, and that can be delivered by any appropriate member of staff. So depending on the competency or skill being learnt, then it depends on who's the best person to teach that, whether that be with a secretary, whether that be with a HCA, whether that be with a GP mentor, practice nurse. So it depends on what the skill is being learnt. And occasionally it might be doing online learning, online modules. And then we would also expect the GP assistant to have half a day a week to write up, reflect, do further reading, and provide evidence to the portfolio towards that competency level. In terms of evaluation, as mentioned, we're going to try and keep it as quick and easy for you all. We know that primary care is a busy place, and we know that if we give you hours and hours of evaluation to do, it's probably not going to be completed fully. However, it is something that will need to be completed, and we do need your cooperation with this if it's going to be a meaningful pilot. We'll be collecting some baseline data, which is partly demographic and partly about hours GPs spend doing certain tasks and things, and then we'll be repeating the questionnaire at the end as well. And it'll be via a SurveyMonkey online survey, and that should reach you in the next week or so. There will be some qualitative and some quantitative data, and we'll also be hoping to get in touch with your PPGs if you're happy for us to do so, so we can discuss the patient experiences and expectations of the role. So in terms of support and how can we support you during the process, all GP mentors will receive a supporting document via email which has some tips and advice on how to meet certain competencies. It's not teaching notes as such, but it gives some good ideas on how to meet competencies. And again, you can speak to each other for ideas as well if you're struggling to identify how to meet certain criteria. There are the potential for some e-learning for health modules, and we're still waiting for confirmation of that exactly, but we know that the London teams have trying to develop some e-learning for health modules, mainly regarding some of the administration elements of the course, and when we get further information regarding that, we'll be certain to forward that on to you and let you know. Now, there will also be some technical portfolio support via Cisco, which is the host of the online portal. We are paying them for that technical support, and they're available online and on phone 5 days a week. We'll also send you both GP mentors and GP assistants, an online guide as to how to use the portfolio system, which should be able to answer most of your queries. And also, I think it's really important we support each other in this. We're all in a relatively unique position in that this is a new emerging role, and we don't have all the answers. And if you want to set up WhatsApp groups or email chains to discuss challenges, to discuss what's going well, to discuss what isn't going so well, then that is a really good idea. And then if lots of you are struggling with the same thing, or lots of you have a problem with something, you might be able to help each other, or equally it might mean that we need to look at something centrally. So it is a really good idea to stay in touch with each other and support each other through the next 6 months. If there are problems or uncertainties, please do speak to us and we will help out wherever we can.